Still watching this morning on ITV. Like we said before the break, when we are back, you are going to be seeing the face of the number one medical doctor in the FCT, who is the chief consultant in the Surgeon National Hospital in Abuja, Dr. Charles Gwine. Very good morning to you.
Thank you, my friend. Thank you. Happy to be here.
Yeah, my colleague Hope Brown is also here. We're going to be looking at the of course, plan sanctioned by the federal government on any health facility or medical doctor that refuse to reveal the identity of the drugs prescribed to patients. And that actually came when the federal government, in collaboration with the World Health Organization, marked the World Patient Safety Day. Doctor, of course, it's something that we are worried about, and it's only you who is the number one as far as medical doctors are concerned in FCT should respond to this.
Thank you very much. I am happy to be here today to clarify some of these issues. Let me start by saying that it is not a matter on the table for discussion that patients have an inalienable rights to know what medications that they are being given in the course of treating their illnesses. As a matter of fact, it is enshrined in the traditional clinical methods that once you establish a diagnosis, you have to discuss treatment with the patient. Whether it is medical treatment or whether it is surgical treatment, whatever treatment you prescribe for the patient, you sit down, have a discussion with the patient. For every medication that you are going to give to the patient is his right to know what that medication is meant to address, how that medication is administered, the dosage of that medication, how that medication works, how it's eliminated from the body, and then the side effects of those drugs. In fact, you are supposed to, as a clinician, and we normally do, ask the patient to give us a feedback on how the body reacts to that medication. And if it needs to come back for a review of that medication, you make an early appointment. But if there is a serious reaction,
sorry, sir. Let me hold your thought there. If you need to come back, we'll continue from there. Let's go on a very short break. All right, before that break, Dr. Ogwanyi was making a point on the need for patients to come back after the drugs have been administered.
Yes, it's important that we get a feedback from these patients on how this drug is interacting with his body. Yeah, because you have situations where some patients have idiosyncratic reactions, unexpected reactions, and it's important that we get this feedback. The issue of doctors hiding medications from patients, is not in line with the modern practice of medicine. As a matter of fact, I can assure you that there's no single doctor practicing in this FCT medical space that engages in such quackery, because any doctor who hides the identity of any medication from any patient is not practicing modern medicine. Let us be very, very clear here that, there are a lot of quacks all over the place, and those who practice quackery, first of all, they do not have basic training, neither do they have basic understanding of how these drugs work. And therefore, it is important to know that you cannot give what you don't have. They don't understand how these drugs work. They don't understand how it interacts with the human body. So they are unable to provide this information. So we need to separate those kind of doctors from the cream de la cream of the doctors that we have in NMFCT. And by implication, the whole of Nigeria. I don't think there's any doctor who is properly licensed and registered with Nigerian Medical and Dental Council that has not been properly trained to use drugs safely on patients. And it is our pride, actually, to make information available to patients. So it's nothing to do with the Nigerian Medical Association. We are at the forefront of making sure, in fact, it is to our benefit that patients know what we are giving them. And as a matter of fact, patients are very enlightened now. it is unlikely that an educated patient will consume any medication, food, drugs, without knowing what it's going to do to your system. It is unlikely. Okay. So I think the emphasis should be on sieving out the quackery in our system and concentrating efforts to deal with quackery, because you find those elements in quack practices. That should be the focus.
Okay. So one of the rights of patients, according to the Patients Bill, it says that they have rights to urgent, immediate, sufficient intervention or medical care in case of an emergency. And we hear stories about emergency situations where those patients will be asked to go and get a police report before they can be attended to. So is that not a violation of the rights of patients in that regard?
Well, I can assure you that this is a matter that has been in the front burner for some time now, and different poor hospitals have adopted different policies, both public and private hospitals. And but the key thing is that the attention should be given to the patient, especially in life-threatening situations. So the other aspects of legality, the getting police report, it's being handled in different ways by different hospitals. But we as care providers, we are always focused on saving the life. Then we let the system use the internal mechanisms there to deal with the police reports and so on and so forth. Our primary focus as clinicians is to save life. But of course, we're operating within the confines of an establishment, rules and regulations. Yes.
Okay, you were talking about quackery, and I was imagining, why would a license be given to an hospital where you are not even sure of what service can be provided from such hospitals, and they got license to operate, as a hospital? So the quackery itself should have started from the onset, at the start of such kind of hospital. So do you have a body that checks, before they give a license to hospitals to start operating?
Absolutely. There are different levels of licensing. Licensing of doctors is being handled by the MDCN, Medical and Dental Council of Nigeria. It is their duty to make sure that every doctor practicing within Nigeria is properly licensed. And there are procedures for licensing. Fresh from school, you're given provisional license, which is converted to a full practicing license after you complete some mandatory training. And if you have been in practice, they make sure that you attend regular courses, continuous medical education, and your license is being renewed every year. Therefore, if you don't meet up with the requirements, it is unlikely that you're going to be licensed to practice next year. And they have put a lot of checks and balances to make sure that they enforce this, and anybody who is not licensed is not allowed to practice. All right? So MDCN is handling that at the individual level. But now, at the hospital level, establishment of hospitals, public, private hospitals, every state, for instance, in the FCT, you have a well-recognized body, PHARC, in the Federal Capital Territory Administration. Their job is to make sure that every hospital that is being commencing operations newly is duly licensed, and this license is also renewed annually. And they conduct checks to make sure they check the quality of the doctors, the current practicing license there, they check the equipment in the hospital, they check the hospital environment, how safe it is for the patient. So there are different levels of licensing. Therefore, if it is done properly, it is unlikely that quackery is going to be encouraged. Now, let me give you a little bit of information. Quackery is something that has been around for a long time, but you see, it is gradually being pushed away from the center. It's happening more at the periphery of the cities, because the center does not provide a conducive environment for quackery to thrive. So there's a lot of work going on there to chase them away. but it has to continue and chase them away from the periphery, because we have a lot of people living at the outskirts of the city. Yes, and it is thriving a lot there. And then again, patients are also not helping matters, because patients have decided to engage in some unwholesome practices whereby they begin to prescribe for themselves, and then they begin to prescribe for others. For instance, that a drug was prescribed for you 2 months ago and it worked to cure that ailment at that point in time, does not mean that when a similar symptom comes up in the future that you should go and do self-medication. And that's what they do. What has happened previously does not necessarily mean that it's the same thing that's happening right now in your system. It's absolutely important, and we send this advice out there that patients should go back to hospital and get re-evaluated, even if they think it is the same symptoms that are coming up again. Because the way your systems were working a few months back does not necessarily mean that is the same way they are working right now. And sometimes you have some symptoms of different diseases that are looking similar. So it is not likely that what happened to you a few months back, the same thing happening right now. And taking it further, they even begin to consult other patients. No, when I have that symptom, this is what the doctor gave me, and then it begins to administer to another person. This is absolutely unacceptable, and it should be condemned.
Okay, on the side of doctors too, when
Yes.
we condemn patients, we have this very unpleasant behavior from practitioners. You have paid for tests have been conducted, you have difficulty in getting your test result. Why is it so?
Well, it is very strange to receive that sort of complaint, because if you look at how the systems work, you have the laboratory. The laboratory is charged with responsibility of processing these results, these tests, these samples, to generate a report. And for what is happening, we're even moving away from the analog to the digital system where these results are transmitted. And in well-established hospitals, here in Abuja, National Hospital, Gariki Hospital, and so many of them, public hospitals, the doctor is sitting in his consulting room, and just a tap on the computer, the results are all there. But even from the analog system we are coming from, I do not understand, and we do not find any reason why a patient has paid for tests and he will not collect his results.
So what are you doing about that? Because it is something that we tackle most time, and personally I have been in a facility where the woman came and said, give me the results. She was at the front desk, and the person said, no, I'm not giving it to you, you have to pay. And she left that place crying. I had to call the medical director and explain what I saw with my eyes, and he wasn't happy. But it happened in the hospital, it happened with medical doctors under your jurisdiction.
Well, you're bringing in another angle, the angle of logistics. All right? Yes. So it depends on the type of insurance policy you have, the type of payment package the patient has. But you need to understand that healthcare services anywhere in the whole world is not free, and it is not cheap. So if there are financial obligations that you're supposed to meet and you haven't been able to do that, very few hospitals will release the result. If that is the reason, it is beyond my scope of discussion here, because I'm not getting into the logistics of processing lab investigations. Yes, but let me leave it and let me pass a message to the general public that you need to find which system is working for you. Are you using the insurance system to pay for your treatment? Are you using out of pocket? Are you using community insurance, church insurance, whatever? But you need to be able to deal with the logistics. Otherwise, you will come back to that hospital next time and it's no longer functioning because they cannot sustain the services. So we're encouraging patients to find a workable means of paying for the services. And what most people are doing now is to be properly registered with insurance. If you have good insurance, you don't need to be worried about payment. But it's a disservice to the system to come in with no form of plans for payment, and you're expecting the system to perform magic. It doesn't work anywhere in the whole world.
I would like to add something on that insurance, but let her go on.
Okay, I wanted to talk about the fact that patients are seen as entitled to quality care, you know, from different hospitals they go to, in accordance to prevailing standard, you know, we have in the country. And at the end of the day, they don't get that quality care, you know, as expected. Do they have what they can, you know, cry to, where they can lay complaints? And will such complaint be addressed? Do they have a way they can sanction such health providers if they can't give that quality care patients need?
Yes, well, I'm not sure I understand what you mean by quality care. But like I said from the beginning, we practice clinical methods. Clinical method is a system that we have been taught right from medical school, and it guides you through your whole career. And that process is standard. It leads you to establishing a diagnosis, right? And once you establish a diagnosis, you discuss treatment with the patient. Now, you are not operating alone. So I'm talking of checks and balancing. Doctors will work in small units, small groups, teams, departments, clinical directorates, top management. So at these different levels, we have what we call checks and balances, ethics audits, to make sure that we are giving the patient the best treatments available. So I can vouch for my doctors working here in the FCT that we provide quality care in line with established clinical methods. However, doctors, we are mere humans, and we practice science, we practice medicine. Science has not answered all the questions. It is not every illness that modern medicine has been able to address. I hope you understand that. Yes. We know that from a medical point of view, and that is why we engage them continuously. This is your problem, these are the challenges, this is what we're achieving, these are not achievable. It is not achievable for us to tell you that we are curing you of stage 4 cancer. We cannot achieve that. But if the expectation of the patient is beyond what modern medicine can offer, you begin to get such complaints. However, those complaints are most welcome because they help us to perform better. We're not afraid of complaints. But what we preach against is how you lodge those complaints.
It's just that
we do not tolerate any means of violence against the doctors. And in fact, we have launched initiative and we are putting message out there, don't use violence. We want you to use civilized means in every hospital. You can lodge complaint through Servicom. Okay. Servicom, all of us, we know Servicom. Every public hospital, even private hospital, have Servicom box. Lodge your complaint there, it is dealt with. You have Public Complaints Commission. In fact, our regulating body for private hospitals, PHERC, FCTA there, you can go there, lodge your complaint against the hospital. On individual level, you can even take on the doctor. You go to Nigerian Medical and Dental Council and lodge a complaint. They have various portals, tribunals, to try perceived negligence. We are not saying that we're infallible, we're mere humans, we can make mistakes. Yes, there are verifiable cases of medical negligence, no doubt. But we want you to follow the due process, deposit your complaints, and be sure that you're going to get a fair judgment, fair assessment. And if any doctor is found culpable, MDC and they don't spare you. They're very fair.
Okay, now let's look at HMO. Hey, you know, the reason why you discover that some persons don't want to do the insurance scheme is the fact that when they go to hospital, they are told your package stops here. It doesn't go beyond this package. That is an issue. Again, I give you an instance where one of the CMD said, look, for that patient, don't go beyond 1,500 naira treatment for malaria because the HMO says it should not go beyond that. And the CMD and the hospital, they are tight. Why? Because the person will say, I came to this hospital, I was treated, and it was not effective. How do we tackle this?
Well, it still boils down to the issue of funding in the health sector. the health systems we operate here is based on, it reflects, we have three types of health system, which is reflected in the general governance architecture in the country: local government, state government, and federal government. Yes. So, and they have adopted, basically what they have adopted in this country is either out-of-pocket payments or the National Health Insurance, currently changed from the Health Insurance Act, NHIA Act. Now, if that act is properly implemented, it is going to provide a reasonable level of care to patients. But for what is happening right now, the the current insurance we have is unable to go beyond what it is doing right now. I'm aware that so many hospitals that are under obligation to provide care for patients under this current arrangement, they are heavily indebted. They are heavily indebted because they have provided more care than the returns they get from the yes. So how can it work? It isn't working. But we are happy also that the relevant ministries, agencies, they are taking a second look at it. Let me give you an instance. It is difficult to provide any major surgical intervention based on what the health insurance can provide right now. And what tends to happen in most institutions is that they say, okay, this is how much insurance will take care of, then you pay the balance. And you'll agree with me that most people are not even able to pay that balance. And in emergency situations, the hospital will not fold its hands. They will provide that care, which means they are incurring debts, they are incurring bills. These hospitals, they don't manufacture drugs. They get supplies from pharmacy companies. They don't manufacture laboratory reagents. They get supplies from companies, laboratory lab reagent companies. These hospitals, they don't manufacture CT, radio diagnostics. They have to import technology and sign maintenance contracts. They have to pay. So I'm talking from my experience in National Hospital. We incur so much expenses looking after these patients. And the bill there is the bill is huge. The bill. How do you expect those hospitals to function? I'm not holding brief for anybody, but I'm just giving you the practical reasons why the National Health Insurance Act should be made comprehensive, like we have in the NHS UK. NHS UK takes care of you from cradle to grave. Therefore, what the government should do is to design means whereby everybody pays.
Okay, before we go, our time is flying fast, Doctor, is the brain drain issue, and the FCT is not left out. You just attend, hospital, you get a particular doctor attended to you, you are coming back the next time, you are told it's not there. Why are you allowing your doctors to leave the FCT?
Honestly, we are appealing to our doctors to stay. But that appeal has reached its elastic limit. The reason is that there are a lot of push factors pushing them out of this country.
Yeah, and you can stop the push.
There are a lot of pull factors over there. Now, starting from the push factors here, the remuneration is abysmally poor and low. The work environment is not enabled. The security situation is in total disarray, as we all know. And these are the things people are looking at. Out there, those constitute the pull factors pulling them. Let me even tell you what is happening now. The resultant effect of this brain drain is that we are drifting far and far and far away from the WHO recommendation that for a decent healthcare provision, there should be 1 doctor to 600 people. That's what WHO has recommended, and that's what's happening in developed climes. In our environment today, we were at one doctor to 4,000 people, but now it's gone above 1 doctor to 5,000 people. How is that going to work? What is happening now is that the job that is supposed to be done by 4 people is being done by 1 man. And what do you expect? I'm aware that doctors are collapsing in their places of work because you have to be on call continuously for a long time. And when you're on call, you're working morning, afternoon, night, morning, afternoon, night. After some time, you will break down, you will drop. So to make it more complicated, you know, there is a government policy that you don't just replace doctors that are living like that. So I'm aware also that there's ongoing discussion now to reduce the bureaucracy replacement of doctors. Because normally from advertising a position to employment, it takes up to 8 months, 1 year. We're asking them to reduce it so that even the little left in the system, we can easily absorb them to replace those that are leaving. Sir, let me give you a shocking information. If you go to MDCN registry today, we have 110,000 doctors registered. Their names are there. But as at April 2022, a few months back, the number that have renewed their annual practicing license is just 55,000. Where is the rest? Where are they? Well, maybe a few have died.
Maybe they have stopped practicing.
Maybe a few have died, but most of them have emigrated. You know what they call jackpot.
Okay. So before we go, you made a point, and I want to say that point you made actually contradicts what the Minister for Health said recently about we having enough doctors in the country to meet the needs of patients in the country. So I don't know where this contradiction is coming from, because you are saying we're having a doctor to 4,000 patients, and it's contradicting what the minister said.
I am not here to join issues with anybody. I'm giving you facts and figures that are verifiable. All right? You just said that you went to hospital and the doctor you saw the other day is no more there. You said it yourself. Let me tell you, there are some hospitals that they've closed down some units in the southwestern part of the country. They're closing down some units because the doctors have gone. They cannot sustain those services. This is a reality. And it cuts across all cadres of doctors. It used to be young doctors living, but now even older doctors are living. So it is, in fact, I call it a pandemic.
So before, in 30 seconds, how can you stop it? You, as the NMA chairman, how can, in 30 minutes, 30 seconds?
Well, I'm not sure I can stop it, but I can only appeal to our colleagues to put patriotism before personal gains. Beautiful. Considering the fact that nobody will repair our system more than we can do it for ourselves. So it's only patriotic drive. But however, that patriotic drive must be oiled by necessary government interventions.
Thank you so much, Dr. Charles Igwani, Chief Consultant Neurosurgeon, National Hospital, the chairman NMA FCT. Thank you so much for your time with us. Patriotism is key to everything we do. With patriotism, even medical doctors will not deny patients their right in terms of the identity of the drug they are offering, the treatment, the result, the test result. With patriotism, medical doctors themselves will not be jetting out in search of greener pastures. We are also aware that when they go there, the workload is bulky. So it's just that they have gone and they just want to remain there, just to, feel among those that are there. Thank you so much.
Thank you. I'm happy to be here. Thank you.
Right. So we'll take a quick break. When we come back, it shall be the concluding part of the program. Stay with us.
Good.